I'd like to welcome everybody because I see also the participant list actually growing. So I'd like to welcome everybody for this session. So it is the third session on neoadjuvant and nanomedicine for cancer treatment. So now I would like to welcome Dr. Sirin Adham. Sirin, it's really nice to see you. I hope also that you'll be able to stay for the entire day today because it will become really late. Oh, you're in mute.
Oh, yeah. Can you hear me now?
Yes, I can. Thank you.
Hi, everyone.
So Sirin is going to talk about a new correlation between neuropilin-1 levels and breast cancer response to neoadjuvant chemotherapy, bed to bench data. Sirin, the floor is yours.
Thank you. I will start sharing my screen right now. Okay, I guess you have my screen on your computers right now.
Yes.
Okay, excellent. So I'll start now. So thank you for inviting me to this interesting and very interesting actually talk. I'll be actually talking about the new correlation between neuropilin-1 levels and breast cancer response to neoadjuvant chemotherapy. And as you see, it's not as usual bench to bed. I will be starting by the bed and then moving to the bench data. So neuropilin-1 is going to be a protein that I will be talking about in a bit and define a few things because I know that we have some students joining in this conference. So why I didn't say bench to bed, because my project started from the bedside, going to the, let me take my pointer here if I can. Okay, so starting from the data from the patients, and then we are moving now through this route, which is a bed to bench. So basically, I have a few things. I'm sorry if you already know this information, but I'll be talking about locally advanced breast cancer, which is a cancer known to have advanced stage primary tumors with extensive nodal involvement, and it's also known as inflammatory breast cancer. So breast cancer in general is classified into 5 different molecular subtypes, and those subtypes are globally known right now because 3 main biomarkers, the hormone receptor for estrogen, human epidermal growth factor receptor, the progesterone receptor. So whether it's absent, the presence of these 3 receptors on tumor cells defines the subtype of breast cancer. So we have the luminal A, luminal B, luminal B-like, and the famous, which doesn't have any of those markers, and it's known to be the most kind of lethal subtype since we don't have targeted therapy for this kind of cancer or subtype. And then we have the HER2 type. So of course, breast cancer is managed by a multidisciplinary team of starting from the surgeons, the oncologists, the pathologists, and so on. And it's treated using many different modalities: chemotherapy, surgery, radiotherapy, and hormone therapy in case the tumors are hormone positive. What is known like now, like everywhere or globally, is the 3rd generation treatment for the locally advanced breast cancer using neoadjuvant chemotherapy. So for those students who probably are new to the field, why we call this neoadjuvant, it's because it's given before the patient goes to surgery, and usually it's given to reduce the tumor size to manage it much easier. So neoadjuvant chemotherapy is like given intravenously using few drugs such as cyclophosphamide, adriamycin, 5-fluorouracil for 4 cycles, and each cycle is 21 days apart. And then that will be followed by another 4 cycles with a taxane, either paclitaxel or docetaxel. So that is the neoadjuvant chemotherapy regimen, which is going to be given before surgery, and then it will be called adjuvant therapy after surgery. So I also want to define these few terms here. When we talk about the pathological complete response and pathological partial response, what do we mean? Well, pathological complete response, it's when there will be no invasive residual tumor, and that will be a YPT0, and there will be no involvement of any lymph nodes after the neoadjuvant chemotherapy. Those patients, as we said, like locally advanced breast cancer patients, regardless of the subtype, regardless of anything, they will be always going through the neoadjuvant chemotherapy. And the results will be always, although now there is good news about the survival rate after the neoadjuvant chemotherapy and the usage of that kind of modality and treatment, but we are still facing, I mean, the oncologists are facing the issue of no responders or these partial responders, which means the tumors in the partial responders, it will kind of resolve somehow, but it's not totally. And then there will be like the patient will remain with some residual invasive cancer with some evidences that the treatment is working, but it's not complete. So that brings us up to the idea that the neoadjuvant chemotherapy will not really work on the idea of all size fits all. So each individual will be reacting differently to these kind of treatments. So again, I will also define what we mean by remission and relapse. Remission is when the patient is completely going through the treatment and it's really responding well, and during all the different tests, laboratory tests, physical examination, there is no evidence of any cancer anymore, but we still call those patients in remission. The patients who are going to be relapsed are those with some kind of resistance to the treatment, and definitely they will have recurrence cancer, which is going to be evidenced, of course, by the clinical tests. So all this brings us up to the idea on why all this is happening, why some patients are responding well and the others are not. I guess nowadays, since we are in the era of the omics, and we have seen very beautiful talks yesterday about the whole genome sequencing and the powerful and the power of all these different techniques, brings us to the idea of the precision medicine, which is one of the aims of my project, which is looking for a new biomarker specifically for triple negative breast cancer in order to try to find more targeted therapy for those group of patients. And therefore, the idea of precision medicine is to prescribe according to all these data that we get from these different platforms, so that we are treating specific patients according to its probably mutations or the genetic makeup, the environmental issues that he or she has. All this brings me here to my own topic, which is neuropilin-1. Neuropilin-1 is a protein you might have came through literature with it, because it actually was found initially in the nervous system in axonal guidance to act there with plexins and semaphorins. But later on, it was found also to conduct angiogenesis through the tyrosine kinase, acting as a co-receptor for vascular endothelial growth factor receptor 2. However, in breast cancer, the angiogenesis pathway was not really the way to go with neuropilin-1. So my idea and my objective of all this project is to find the role of neuropilin-1 in breast cancer. There was lots of literature talking about how neuropilin-1 is involved in progression of breast cancer, but the systematic levels presence of this soluble neuropilin-1 in the systemic or in the blood was not known yet. So the idea started from, as I said, from the patients, which means this project had two arms, where first of all, we knew that neuropilin-1 reacts with TGF-beta, such as these ligands, PLGF and VEGF and VEGF-R2. It reacts with so many different growth factors and receptors, conducting several things in the cell and like inducing all these cellular responses. So when I am targeting this particular molecule in particular, of course, the whole idea about it came because I worked with VEGF-R2 and I knocked down VEGF-R2 in ovarian cancer cells. And all of a sudden I saw that neuropilin-1 was highly expressed, but at that time I was a postdoc at the University of Guelph. We were not able to figure out what was the mechanism, but that was in ovarian cancer. So when I joined SQU and with the privilege having a university hospital, I was able to think a bit outside of the ovarian cancer, because the most prevalent cancer in the country here is breast cancer. So I contacted this group of oncologists and surgeons, and we were thinking of having this project starting from patient samples. So what we did was, in that clinical arm, is we collected the blood samples from about 80 patients, and of course the tissue of those patients before they went through the neoadjuvant chemotherapy, as well as after they went through all the cycles. So in the first study was to have the plasma, the puffy coat, and the tissue, or the biopsy at that case, and studying these locally advanced breast cancer. What is the prevalence? What is the levels of this protein, neuropilin-1? Because those circulatory proteins are holding a potential benefit as biomarkers for precision medicine. So what was the result is that the levels of neuropilin-1 in the plasma, for instance, showed that they were much higher in more metastatic or patients with metastasis, and with more involvement of nodal metastasis compared to non-metastatic patients. So that means still it's telling me that neuropilin-1 in the circulation seems to correlate with worse outcome and with metastasis. At the same time, we also took an age-matched group of patients that they are controlled non-breast cancer patients, and we collected as well the PBMCs, and using real-time PCR, we were able to tell that there is a significant decrease on the PBMCs of neuropilin-1, unlike what we have seen in the plasma and in the tissue. So there is also lots of literature and a Nature paper talking about the expression of neuropilin-1 on the immune cells invading tumors, and how that can shut down the surveillance for the immune system. So again, going back to triple-negative breast cancer, it's very interesting because we found that not only neuropilin-1, but also the ligand, the other one, which is a PLGF, both are increased in their expression, significantly increased in triple negatives compared with other molecular subtypes. So that is something very interesting, and we came up to say that neuropilin-1 is actually or might be a good prognostic biomarker for breast cancer. So at that time, we published this data in scientific reports. If you would like to have more readings, because we speak also about more molecules that they were involved in this whole process. So afterwards, we completed the project looking at what happened to the levels after neoadjuvant chemotherapy. What did the treatment do to the levels? So collectively, we found that the neuropilin-1 expression was highly and significantly increased in all patients, regardless of anything, like just in general, it's increased in post-neoadjuvant chemotherapy samples. But more interestingly, we found that those patients with partial response to treatment, they also had higher levels of neuropilin-1. So that was kind of like interesting, so that those with complete response, they didn't show a significant increase compared with a partial response, which means neuropilin-1 still is there and it's doing something in the circulation. Not only that, we found also in tissue, those patients who are in remission, they showed a significant decrease in the levels of neuropilin-1 in their tissues compared with those who are relapsed. And again, the same thing in survived patients versus the died or the passed away patients. And in using this Kaplan-Meier graph, we were able to tell, although the sample size was not that high, but there was kind of an evidence that patients who remain with high levels after neoadjuvant chemotherapy remain with high levels of neuropilin-1, those are the ones not to make it and can't survive. So there is a decrease in survival rate if the tumor stays with high levels of neuropilin-1. So that also brought us to validate this data and see what happened, why the treatment is increasing the levels of neuropilin-1, and if it's not resolved, then the survival rate decreases. We found also just taking MDA cells and treating them with the same kind of cycle we made this resistant kind of cells to the 4-XAC or 4 cycles of adriamycin cyclophosphamide plus the paclitaxel cycles, we found that, yes, it's pretty much the same as what we have seen in the patients, that these kind of treatments, they are increasing the levels of neuropilin-1. But what do they do? At that time, we decided to knock down the gene. So we knocked down neuropilin-1 with different levels. So we have got 2 clones with different levels of neuropilin-1. And interestingly, once we conducted the gold standard, I would say, test in vitro for drug and sensitivity, which is the colony formation assay, we've seen that there is a complete sensitivity triggered after the knockdown of the neuropilin-1, and it was very much going with the same kind of trend. So the lower the neuropilin-1 expressed, the more sensitive these cells become to treatment, whether it's like this is untreated and then this is the treated with adriamycin cyclophosphamide and paclitaxel. So we all know that paclitaxel is a mitotic inhibitor, and it will also affect the control cells as well as the knockdown cells. But it's very obvious that the neuropilin-1 seems to play a role also in resistance to chemotherapy. So we got the conclusion saying that neuropilin-1 might be also a potential predictive biomarker for breast cancer response to chemotherapy. And this was also published in Frontiers in Oncology. So we said also we would like to understand now in terms of like the subtypes of breast cancer and what does these different drugs do if we have different types. So we decided to do this kind of model of making these cells resistant, not only MDA, but also MCF7 cells, by treating them with like different dosages of the drugs, the same drugs that they were actually used for patients. And we were selecting all these resistant cells for a span of almost 1 year. Got that, and then we performed all these different RNA-seq for for those kind of cells, and we were able to spot some molecules that we were able to validate using Western blotting, that the resistant mechanism between MDA and MCF7 cells is completely different. And that is really subtype dependent and even drugs dependent. So if we take a look at neuropilin-1 levels here, we see like after all these different cycles of chemotherapy, the protein is getting upregulated. And by the way, if anybody has ever checked the levels of neuropilin-1 in these cells, it's so high. So that is a very low exposure. You can see that it's very high, it's massive. So what is the here? So in MDA, it seems that what happens is that neuropilin-1 seems to be involved in such kind of resistance to such treatment. But at this time, we've seen that breast cancer resistant protein, for instance, was downregulated. So as if it's telling the cells, okay, we don't need that kind of resistant mechanism, we have a different one. And it seems to me that integrin beta-3 and focal adhesion kinase is the one mechanism which is involved in the whole story for this kind of cells to be affected. So the integrin beta-3, phospho-FAC, and even the phospho and FKB survival pathway was also upregulated. So then we all know that MDA is mesenchymal kind of cell line. So we also looked into some proteins with evidence for going like from epithelium to the mesenchymal transition. And all those molecules such as vimentin and ZEB1, they were upregulated in these resistant cells. Looking at the cellular behavior, MDA doesn't usually form good type of spheroids and strong ones. These are really fragile. If you move the plate, they will just disperse. This became a bit worse when the cells became more resistant to the treatment. So they were like able to grow like not in a spheroidal fashion. The other cell line which seems to be also affected is the MCF7 cell line. And here we have completely the opposite pattern. If we go back to the slide here, you see the amount of neuropilin-1 upregulated and the amount of BCRP. In MCF7, we have the opposite. Neuropilin-1 was downregulated in these resistant cells. However, breast cancer resistant protein was upregulated. And looking at the same pathway, which was affected in MDA, we see like we are still seeing integrin beta 3 is going up. However, phospho-FAC and the phospho-NF kappa B completely got the opposite pattern. So the same thing we've looked also since we also looked into the cellular behavior, and we looked into how the cells behave in terms of spheroid formation. We've seen these ones that we usually call them mammospheres rather than a spheroid, formed after the 4 cycles of AC. So here we are talking about drug sensitivity, like it's not the same as when they were treated with paclitaxel. So in that case here, we went and we checked also all these different adhesion molecules. And it seems, yes, the mammosphere formation here was because of all these different adhesion molecule, I would say, upregulation in the AC, which were inhibited by paclitaxel. So more interestingly, the MCF7 cells are known to be luminal A subtype. Now, in this kind of resistance, it turned out that these MCF7s became HER2 positives. And this is something that was so, like, they have seen it in like clinical practice, the change of the subtype of these breast cancer after treatment. And here MCF7 is one of those which gained HER2. So looking at HER2, the phospho-HER2 and even phospho-EGFR, all of those, even ER got upregulated. So we went into like time. So those were resistant cells for a year. So we went through very short time and we looked at what happens. Of course, our major protein that we always want to validate is neuropilin-1. So when we looked at neuropilin-1 in these MCF7 cells treated with different amounts of cyclophosphamide, iduronate, and paclitaxel, we found that HER2 has followed the same kind of pattern. It's also upregulated. Well, these cells, they are not supposed to be HER2 positive. What triggered HER2 to become upregulated? So of course, we've looked into different molecules like that they belong to the epigenetic modulation, and HDAC4 and HDAC3 were both upregulated in these cells. The NMT has, again, different fashion of expression. So what came to our mind is to check whether neuropilin-1 is also binding to HER2. And that is astonishing. Yes. So when we have done the HER2 IP, we found that neuropilin-1 is, yes, it's attached to the protein, and in particular to HER2 intracellular domain. So that was one of those things that we brought up again to talk about neuropilin-1, and because it actually binds to so many things. So again, HER2 is another one of those tyrosine receptors, and neuropilin-1 is binding with it. So we came up to talk all these kinds of attachments with other cell lines as well. So for example, BT474 is a HER2 positive, and it's a triple positive cell line. There is an evidence an attachment, but it's more obvious in the MCF7 cells, which changed completely the subtype. So we came up to conclude that neuropilin-1 might be a potential diagnostic and drug target biomarker for refractory breast cancer. Therefore, we published this work like recently at the beginning of last year, 2020, in British Journal of Pharmacology. So that's about my whole project. I tried to compact everything together. And of course, before I leave, I would like to thank my former PhD student who worked on the in vitro part. And of course, both of them, Dr. Aditi Naik is a postdoc. She was in my lab as well. I would like to thank all the clinical team who helped in collecting the samples and following up the patients. And of course, I can't do this without having funded by the Research Council of Oman. Thank you so much. Happy to answer your questions.
Thank you very much, Sirin.
You're welcome.
It was a very, very nice talk. Can you stop sharing? It
Sure.
was just to see everyone.
Yes. Yeah.
Thank you very much. So Myron has the first question.
Hi, Sirin. Very nice talk. Excellent. My question here, there's quite a bit of literature.
I don't see a mother in your contacts.
Hang on. there's, sorry, there's quite a bit of literature now just coming out that neuropilin-1 plays a critical role in facilitating COVID-19 infectivity, and it binds to the ACE2. And I'm just wondering here, most of these patients do have inflammation developing. And I'm just wondering in the cancer, whether the tumor microenvironment may have a role to play in upregulating neuropilin-1 and facilitating the interactions.
Yes, in fact, Myron, I had also another study project where we looked into the tumor microenvironment and its involvement with neuropilin-1 expression. And there is an evidence that, for instance, hypoxia and hypoglycemia are also playing a role in changing the levels of neuropilin-1. So yeah, I've seen that interesting paper which came in Science talking about like the targetability of neuropilin-1 for COVID. And it's not a wonder, because neuropilin-1 is, again, it's a binding partner with VEGF-R2 and conducting like vasculogenesis beside like angiogenesis. So all these kind of clots that we hear about and all these different symptoms of blood clotting, it's because of that, I guess.
Do you have any evidence that the neuropilin-1 is co-localized with the receptors without being activated? Is it, or you have to be activated in order to come co-localized?
Yeah, well, I guess since I said like it is a soluble form and it's a membranous form. So the membranous form, I guess for sure neuropilin-1 doesn't have a binding site for phosphorylation or anything. It just binds to those, receptors. And I would assume that it will always help in phosphorylating to conduct the signal. So yeah, I guess. Well, there was one of the papers previously talking about like VEGF-R2, for instance, binding to neuropilin-1, and then it returns to go to the nucleus to control its own expression. So that's what I know.
Okay. Thank you very much.
You're welcome.
Thank you. I actually have a question. So when you're looking at neuropilin-1 and so the increase as well, so it's wonderful to be able to have a marker, but you saw also the effect of the neoadjuvant treatment. Do you have any insight on what should be modified in the treatment to improve the outcome?
Yes, very good question, Cecile. I think what we suggested in these papers is that at least we have to check the levels of neuropilin-1, because Genentech one time they made like a monoclonal antibody for neuropilin-1, but it stopped at, I think, like preclinical, not preclinical. I think there was a phase 1 clinical trial with that drug, but they found that they used it along with bevacizumab, which is an anti-VEGF. So the usage of these two, they led to an increase in blood urea, I guess, protein urea, sorry, and then they stopped using it. So I don't know why at that moment they stopped using this drug. I mean, we are all hoping that, okay, this is a biomarker, it's upregulated in higher progressed cancers. Why we don't target it? And it's not something new. I mean, 2014 was one of those studies done on patients to see whether we can use it. So the take-home messages was from our project is that please check it. It's good protein to check, because the levels are always high in more advanced disease, and those patients that they are not resolving the protein level after they result to pass away, and it's not good. So yeah, that's the thing that I would say in terms of the advice for what we can do to improve the treatment.
Thank you.
You're welcome.
Myron, I see. Oh, you just lower your hand, so that's you have another question?